Dear friends and colleagues, it is a great honor for me to be a speaker in this 16th Turkish HBP surgery meeting. Today, my topic is minimal invasive hepatic dissection. Actually, I give a lecture in the morning, but because of family ceremony, I had to depart early. That's why I have a pre-recorded video. My apology. I hope your kind understanding. I have no conflict of interest. Dr. Mustafa Kerem and many colleagues have joined us in Busan. Blunt is around here, and also Fatih is around here. Laparoscopic liver surgery evolving. First, I speak about consensus conference because this is minimal invasive surgery. To know consensus is good. And second, I speak about stepwise progress of lap liver dissection. And lastly, I speak about pushing the limit, leaping the boundary of lap liver dissection. First, I speak about consensus of lap liver surgery. In 2008, in Kentucky, Louisville, in USA, there's a very important meeting of international conference on lap liver surgery. I happen to be the panel of this meeting. I sit Joe Buer and Daniel Cherokee and me and Bryce Kaneko. At this meeting, a very important message was decided. Laparoscopy approach for left lateral section to become standard practice. Before this meeting, lap liver surgery was criticized. But after this meeting, first, this surgery become a standard practice, although it's only left lateral sectionectomy. A second conference was held in 2014. I also joined this meeting as well. In this meeting, same minor liver dissection is okay, but major liver dissection is still risky procedure associated with novelty. So there's a caution that major liver dissection is still risky procedure. Yes, laparoscopic major hepatectomy is a difficult operation for common surgeon. To overcome the limitation of lap liver surgery and standardize this surgery, we need a society. That's why we made the Society of International Laparoscopic Liver Society. First meeting was held in 2017 in Paris. This is the first 7 officers, Daniel, Nicolas, Luke, Go Wakawashi, Joe Buell, David Gellert, Olivier Soren, and me has been an officer first. Second meeting was held in 2019 in Tokyo with Professor Go Wakawashi and Professor Tanabe. This is the executive board of second meeting. Third meeting is planned to is resumed to be held in New York, but because of COVID-19, it was a virtual meeting. 2023, just 2 months ago, ILS Rome was held in Italy, so it was very informative meeting as well. Second, I speak about our experience of progress of lap liver dissection. In our institution, we try to do from the easy one to more difficult with the accumulation of the experience. The controversial area is a tumor located in right posterior or superior area, and tumor close to major vessel, including caudate, is a controversial area as well. Large tumor is also a controversial area. We will talk about this. Posterior located in the right lobe and central located tumor is still difficult location for laparoscopic liver surgery. As you said, in our institution, we do step-by-step approach toward more complicated cases. We did first simple cases, then we slowly moved to the more complicated cases. As you know, right post-sectionectomy is a resection of segment 6 and segment 7. this right prostatectomy is still challenging procedure. I hope this resection line looks like a right prostatection resection line. We have a privilege to report on the total laparoscopic right prostatectomy in 2006, about 17 years ago. This is worldwide first report. After 9 years later, we have more cases of right prostatectomy. Then we analyzed our result in 2015. When we compared open versus laparoscopic surgery by right prostatectomy, the overall survival and disease-free survival is similar. So although right prostatectomy is a difficult operation, in selected cases, the outcome of laparoscopic surgery is similar to open surgery. This is our conclusion. How about posterior superior? Posterior superior is 7.4a, 7.7, 7.8. This is also a difficult area. We have reported that the right posterior superior segment is unfavorable location and anterolateral segment is favorable location. I hope this looks like a posterior superior region as well. Resection of posterior superior part is also a difficult operation by laparoscopy. In 2008, about 15 years ago, we have reported on the feasibility of lap liver resection for tumor located in posterior superior segment. In this report, our conclusion is that the outcome of laparotomy liver resection for tumor located in posterior superior segment is comparable to tumor located in anterolateral segment. It is 2008. After 8 years later, we have more cases of posterior superior segment. Therefore, we have compared posterior superior segment to anterolateral segment. Anterolateral segment is regarded as easier segment. We have case match analysis between the posterior superior and anterolateral segment. If you look at this graph, left is overall, right side disease-free survival. Thick line is posterior superior, dotted line is anterolateral. There is no difference between posterior superior and anterolateral. In disease-free survival, there is no difference between posterior superior versus anterolateral. Although posterior superior segment is a difficult location, if well performed, survival is similar between posterior superior and anterolateral. This is our report conclusion. I'd like to compare the operation as a sport. Operation is like a sport. Lap liver resection is a relatively difficult operation. I'd like to compare lap liver resection as a ski. If you go to ski trail, you can find some sign dangerous. This is very expert only area, and the sign I showed, this is a easier, moderate area. So if you are good at lap liver resection, if you have enough accumulated cases of lap liver resection, you can enjoy difficult area like right prostatectomy or posterior superior segment. But if you are a starter or a moderate in lap liver resection, you can enjoy a more easily accessible region like anterolateral segment. As I said, major liver resection is still a difficult area. 5 years ago, we have analyzed our result of outcome of major lap liver resection. Left side is a laparoscopic liver resection group. Right side is open liver resection group. Operation time is a little longer in laparoscopic group, but hospital stage 7 days shorter, and complication rate is much less compared to open surgery. So major liver resection is a difficult operation, but if well performed, the perioperative outcome is better compared to open surgery. If you look at the 5-year survival rate, laparoscopy is blue. This is overall survival, similar but tendency of better. This is disease-free survival, right side disease-free survival. Laparoscopy is blue line. There is no difference, but tendency of better survival. We have studied the propensity matching between laparoscopy versus open liver resection for hepatocellular carcinoma. This analysis is very special that it included major liver resection and it included all difficult lesions like superior 7A. So all our cases has been included. If you look at 5-year disease-free survival rate, laparoscopy is 44%, open is 41%. There is no difference. How about overall survival? 5-year overall survival is 76% laparoscopy and 73% open. In the graph, there is no difference. So laparoscopy is better in perioperative outcome, but the survival outcome is similar between laparoscopy and open surgery. Lastly, we go to leaping the boundary, push the limit. Still, large, central, multiple HCC is a controversial area. This is the report from the first consensus meeting. Large, central, multiple is not indicated for laparoscopy approach. How about large hepatocellular carcinoma? In 2015, we reported, is large hepatocellular carcinoma still contraindication for lap liver resection? At the time, we compared large HCC more than 5 centimeters. In the disease-free survival, more than 5 centimeter tumor is 34 months. It's a relatively good survival. Overall survival, large hepatocellular carcinoma is 61 months. So even though tumor is large, we have a relatively encouraging outcome, 61 months for large hepatocellular carcinoma. But encouraged by this report, we have recently analyzed for laparoscopy versus open hepatocellular carcinoma for large HCC. So this is written by our international fellow with it from Thailand. There are 70 cases of laparoscopy and 70 cases open liver resection. When you compare laparoscopy as shorter hospital stay, blood loss is similar, I0 resection is similar. If you look at this survival, this is propensity score matching before matching, so there is no difference. Lower part is after propensity score matching. There is no difference. Yes, large hepatocellular carcinoma is a controversial area, but if well performed, laparoscopy surgery is comparable to open surgery. How about central located tumor? Central location deep inside the tumor is still controversial area because of bleeding and the accidental major bleeding as well. In 2013, about 10 years ago, we have analyzed our data of liver resection for central tumor, which is very close to hilum, major hepat vein, and inferior vena cava. In this report, only 13 patients. The indication is HCC usually, and vessel is very close to major hepat vein and inferior vena cava. Operation performed right postsectionectomy to two central bisectionectomy, right hemihepatectomy, left hemihepatectomy, including 4 caudate lobe resection. The operation is very complicated operation. Although it's complicated operation, when you compare with open surgery, left side overall survival, there is no difference between laparoscopy and open surgery. Disease-free survival, there is no difference in laparoscopy and open surgery. Some tendency of better survival, but there is no difference. Although central located tumor is difficult operation, but in well-selected cases, laparoscopy survival is similar to open surgery. Recently, we have analyzed the long-term outcome of liver resection for central located tumor. This is overall 5-year survival. Laparoscopy is blue line. So we have seen the similar survival, and this is disease-free survival. Blue line is laparoscopy. There is no difference, but tendency of better survival by laparoscopy. Then we move to multiple hepatocellular carcinoma. In 2012, 11 years ago, we have reported on multiple hepatocellular carcinoma. Compared to single lesion, multiple lesion have lower disease-free survival compared to single group, but overall survival is similar. It's encouraging. Therefore, recently we have analyzed data of multiple HCC. This study is laparoscopy versus open liver resection for multiple hepatocellular carcinoma. Actually, this is written by the Dr. Gianluca Cassese from Italian group. This is Italy and Korea, our hospital collaborative study. This is the overall and disease-free survival rate. The overall survival, disease-free survival is similar between laparoscopy and open group. And beyond Milan, there is no difference in overall and disease-free survival as well. About elderly patients. Recently, we have compared laparoscopy versus open hepatocellular carcinoma in elderly patients. There are 900 HCC patients. Laparoscopy was performed in 127 patients and 49 patients in young patients in open surgery. We have compared. This is a before propane score matching. There is no difference in survival, disease-free and overall survival between laparoscopy and open surgery. And after a propane score matching, there is no difference between laparoscopy and open surgery. Although some tendency of better survival laparoscopy. Anyway, we try to lift the boundary of liver surgery for hepatocellular carcinoma. We push the limit is our mission for liver surgery. I show some slide of anatomic SA segmentotomy. Diaphragm invasion was found. So we first tried to pingular maneuver is performed. Then we isolate right anterior gleason first. Then we try to continue right anterior. Then we try to isolate SA. This is right anterior gleason and isolate it. Then we try to isolate SA. This is SA segment. At the SA segment, we clamp by bulldog. Then we SLE section is performed. This is medial path pain. You follow medial path pain like this. Then we go SA gleason was cut. It's a bulldog. This is SA gleason, and we cut it. Cut. Then you continue. Continue this. This is right hepatic pain. Then we finally right hepatic medial hepatic is very visualized. And diaphragm resection and diaphragm repaired. Anyway, you can see the medial hepatic right hepatic pain. So any difficult operation is possible. How about future? I think robot-assisted surgery will prevail in the future. We will host IALS 2025 in June 24 to 27. I welcome all of you. Thank you very much.
Teşekkür ediyoruz. Son olarak Sayın Başkanımız Mustafa Kerem Hocamız Gulla'ya bir plaket verecek. Dr. Gulla, can we ask you to come to the podium? We have a small gift for your presentation and we appreciate all your effort.